Should we make a start anyway?
Yeah. Apologies to for the delay in starting. For some reason, our speakers were given different names. So we've been trying to locate them, which is why it's taken us a bit longer, and we're still trying to locate one of the speakers at this moment in time. But we'd like to thank you for your patience, and obviously thank you for coming along this evening. The For Many Network launched last year. The aim of the For Many Network is to organise around 12 principles. One of the principles being around the NHS and social care. It's the intention of the For Many Network this year to run a number of webinars on various different aspects of the 12 principles. Could you put that slide up for me, Ali, just so people can see what those 12 principles are? So it's our intention to run a webinar on one of those 12 principles as we go through the different months. For people who are unaware of what the For Many Network is, it's based around hubs that set up in localities and work across different organisations trying to unite the left and work on different campaigns, supporting each other and mobilising around issues we face in our community. We have a number of hubs that have been set up in recent months. We're not a political party, but obviously in some cases the hubs are selecting people that they believe they can get behind in the next general election. But it is our intention to try and cooperate across all different organisations and support and promote the issues of unity and around the issues of our principles. I'm now going to hand over to Mary, who's going to be running this evening, and we will put up at the end the website where you can get more information about the For the Many Network. But I'm now going to hand over to Mary. Good luck, Mary.
Thank you. Thanks, Ian. So our the issue tonight is health and social care. The second principle, the National Health and Social Care Service, fully funded from separate services, fully funded from progressive taxation, which employs directly all who work in it, with no subcontracting and no outsourcing. We have, can we put the next slide up, please? So our agenda today, you've had an introduction from Ian about the For the Many Network and how we're trying to put politics back into everyday conversation. Our first speaker will be Bob Gill, talking about reclaiming the NHS. Our second speaker, hopefully if Nicholas can get in, is Nico Chergo, talking about reframing the NHS narrative for the left. Our third speaker is Leslie Mahmood from Save Liverpool Women's Hospital Campaign. And at some point, we expect to receive, to welcome Jeremy Corbyn, MP, depending on the voting timetable in Parliament. So we may have to cut off and take Jeremy whenever he can get into the meeting. And he'll be talking about campaigning to save the NHS in opposition. We'll then have a summary of the discussions, and then we'll have a call to action at the end with things that we can do. So our aims today are to promote the theme of the principle, which also covers principles 1 and 12, and to raise this theme with members and the concept of renationalisation of services. We're focusing on messaging of campaigning to end the integrated care systems, which are the Americanized, restructured systems that have replaced the Bevan's NHS. And we'd like to talk about reinstating the original model and promoting social care. Second aim is to promote campaigns related to the principles 1, 2 and 12, and to share resources, draft motions, any leaflets, information that people around the country can access and download. So the outcomes we hope will be that people will use the resources that we provide to campaign in their own communities, to talk about these issues, this principle, talk in their friends and their families and their workplaces, to help our members identify targets to raise profile of their campaigns. And we will be putting up a web page where we can share a campaign pack of information. We'll share the recording of this webinar and useful links to websites and downloadable leaflets. So we'd just like to show a couple of clips first before I introduced Dr. Bob Gill. So our first clip is Ken Loach, NHS UROC interview from 2020. Are you running that, Ali, or me? Yeah. Thank you. Have we got sound on that?
Made one of the most audacious political promises in British history. In just 6 months' time, on July the 5th, free healthcare would be available to every British citizen.
I'm proud about the National Health Service. It's a piece of real socialism. It's a piece of real Christianity too.
Why socialism is important, you know, especially talking about the fact what you were saying before, that we have to change a little bit this current system.
Well, it's. I mean, the man you talk about now, Bevan, was he was a left social democrat in a way. He wasn't. He was brilliant. I mean, he was and he created good things, and but he was a left social democrat, and but he created, as you say, our National Health Service, which was an example of socialist practice, in that it was everybody contributed what they could according to their wealth and according to their ability, and everybody took from it the health service when they were sick or they needed help. And it was an example of cooperation, not competition. And everybody employed in the health service was directly employed. So there were no private contractors. You know, whether you were a consultant or you were a cleaner, everybody was employed by the National Health Service. And everybody had a proper union contract. And there was an egalitarian, there was a sense of equality about it. And that, of course, the right wing hated.
Winston Churchill's Tory party had fought Bevan's bill at every stage in the House of Commons. The British papers were predicting disaster. The public would exploit a free-for-all. Finally, on the stroke of midnight on July the 5th, Bevan's dream became a reality. The National Health Service opened for business as promised. Against all the odds, Bevan had delivered, both on his 6-month timetable and on the basic promise of the NHS. Comprehensive healthcare for every person in Britain was now completely free, from the simplest ailment to the most urgent surgery.
Thanks, Sally. And then if we go straight to our second clip of Dr. Bob Gill. Thank you.
The NHS is not for sale and it never will be. The privatisation lobby basically gets underway under Mrs. Thatcher. Electricity, water, gas, the mines, the railways.
Even if you only care about efficiency, the National Health Service should be preserved like a jewel.
There's a sphere of influence that is shared across public and private sectors. And the revolving door, of course, swings both ways.
What the big four accounting firms do is really quite deadly.
PFI has transformed our hospital into a way from actually caring for people and into a means of making profit from the public sector.
Our National Health Service, one of Britain's proudest achievements. Lifting burden from the sick, copied across the world and celebrated in our Olympic ceremony. A complicit media having failed to hold power to account, now busily report NHS failures after years of financial squeeze. Consecutive governments have secretly prepared it for corporate takeover. After years of erosion, the NHS, its budget and very fabric up for grabs. There will be no share offering, no adverts on the side of a bus. This is a robbery for its new corporate masters in the great NHS heist.
The big American health corporations and American health insurers and the American drug companies are absolutely, they're salivating.
These companies are in the business to make money.
Giant corporations, they get caught in fraud and they pay the ticket and keep on speeding.
So they're always vigilant to try to avoid paying for care in one way or another. They were literally kidnapping psychiatric patients and holding them against their will until the day their insurance ran out.
Here in the United States, you might as well be on the moon for the opportunity that you would have to get the care that you need.
No one should ever copy the system.
It is in the sights and the target of the multinational corporations.
Thanks, Sally. And of course, that was a clip from the film, The Great NHS Heist, created by Dr. Bob Gill. If we could have the next, thank you. So Dr. Bob Gill is a GP, an NHS doctor and activist, and his topics are listed on screen now: how the NHS has been repurposed, the current status of health provision in the intended end game. And we're really pleased to have Bob here. Thanks, Bob.
Thank you, Mary. I'm going to attempt to share my screen. So hopefully this all works.
Sorry, can I just ask, can everyone turn their speakers off apart from yourself, Bob?
If I mute all and then Bob unmutes.
Okay, shall I carry on?
Yes, please.
Yeah, so thanks for inviting me and for showing the trailer of the film. I will not try and cover too much, but I want to actually pan out and explain where the threat to our NHS is coming from and who is benefiting and who's going to pay the price. Starting off with a sort of macro view and finishing up with a case study of a patient of mine.
Sorry, Bob, I think I've just muted you by accident.
I titled the talk Genocide Abroad, Democide at Home, because what our consecutive governments have actually achieved over the last 30 to 40 years is a sort of deindustrialization, an increasing wealth inequality, and a pulling away of the welfare state, such that its policies do fit in this definition, which is to cause the premature deaths of the public through their direct actions, indifference, or neglect. A quote from Noam Chomsky pointing out that actually governments on the whole aren't really there to serve the public. In fact, the public are their primary enemy.
And this is becoming more and more obvious to a lot of people, given that the policies tend to make the suffering of the majority worse day by day. Professor Prem Sikka is also Lord Sikka, has written widely on how our economy is rigged. And this particular article is titled "A Neoliberal Coup." And in effect, that is what's happened. Neoliberalism is a political ideology which believes in deregulation, removing public protections, privatization, so opening up the public sector to profiteering, and making or allowing the rich, the super rich, to avoid paying tax. And unfortunately, the NHS has been a victim of this neoliberal agenda. And who do we have waiting in the wings to take the baton from the current Tory leadership? Well, we have Keir Starmer, who has shown himself up to be far from democratic, and he gets the blessing of a very key figure, Larry Fink, who's the chief executive officer of a company called BlackRock. And if you don't know, BlackRock is a private equity firm controlling, I believe it's $7 trillion in funding, who actually shape policies of most of the governments in the West. So you have these large private funds, you have the central banks, and you have these transnational bureaucracies like the EU, like the World Bank and the IMF, that control the policy agenda. And we have a political class which sell as a fairy story as a dress up for the policies that they conduct to benefit the few. I won't show the clip of Larry Fink, but what he does say in this clip is actually private companies prefer to deal with dictatorships and authoritarian regimes because they're far more predictable and more profitable. So these are the people who our politicians are serving. What the film outlines in some detail, and if you haven't watched it, please do, it's free on YouTube, is how these incremental changes to the NHS have largely gone unnoticed, become normalized. New people entering and working in the NHS accept the changes. They don't really understand what the NHS used to be like, but it's now a very bureaucratized, managerial, top-down, fragmented, marketized dystopia. The NHS we have now is not what I want to protect. The NHS we did have, which spent very little money on management, where the clinical teams were making the decisions, which was run on a rational basis, and you didn't have private companies and PFI companies leeching out the budgets. That's the NHS we need to return to. The major changes I want to highlight were the creation of an internal market using the false narrative of driving up efficiency. It did absolutely the opposite, increased the cost burden on the NHS. The use of private finance initiative as a tool for shrinking NHS capacity and setting it up as a financial basket case as PFI debt liabilities became more and more onerous, a very expensive way of borrowing. And then you had the reconfiguration and compulsory marketization in 2012, followed by a 7-year spell at the helm by a Mr. Simon Stevens, hired across from America's biggest private insurance company, United Health. And by the time he left in 2021, all the backroom and organizational changes had already taken place to allow the final bit of legislation, which converts us to an American-style system, to pass through very easily through the House of Commons and through the Lords, where he now sits. So this is the latest and I believe last legislation needed to give the corporates what they want. It went through in July 2022 with zero media attention, very little meaningful analysis, particularly from the unions and the supposed NHS defense groups, with some notable exceptions. What has happened to the NHS in England? It has been broken up into 42 public-private partnerships called integrated care systems. These are controlled by corporations, headed up by formerly people employed by these corporations, the banks, the big four accountancy firms, the insurance companies, and they're put in charge of large budgets to look after 2 to 3 million people. And that budget, whatever money is not spent on the delivery of care, can be kept as profit. And this is on top of the 2012 Act, which in effect abolished the NHS and the duty of the Secretary of State to provide healthcare. So these people now will have the freedom to restrict access, deny care, and reduce a comprehensive provision to a very much more selective provision. Now, more recently, it's come to people's attention that there's a downskilling agenda. What I mean by downskilling is replacing qualified staff with very much less qualified staff. For example, a physician's associate who may have a a science degree at university, unrelated, maybe in chemistry or biology, does 2 years of medical studies and is supposedly now fit to replace a GP who's medically qualified, 5 years clinical experience, 10 years in total, and that's supposed to be all fine. Well, actually, it's a disaster waiting to happen. And has happened. There have been some notable examples of gross failure, misdiagnosis, and people dying as a result of it. And the reason this is a fundamentally flawed idea is if you consider patient safety in a rational system, you have somebody who's very qualified having some input into the patient's journey. Now, what these layers of Swiss cheese represent is that sort of medical and nursing hierarchy that will have some interaction with the patient. And what the government's policies have done is actually made the holes in the Swiss cheese larger and removed layers of protection. So the chances of all the holes lining up and a patient coming to some harm at the end of it have vastly increased, because these doctor substitutes will have a very, very large clinical blind spot, which means the chances of misdiagnosis are much, much larger. Now, this graph might look a bit complicated. The UK is in the middle of that top group, mostly European and developed countries. And what it shows is as you spend money on healthcare, life expectancy improves, but it starts to plateau as the costs go up. The red line shows the American system, which spends much more than every other country in the world, but people are dying at a younger age. Now, what our government's policies have done over the last 4 decades is to replicate the American system with the intention of extracting profit, but as a byproduct, increasing costs to the individual, either through taxation or top-up insurance, and driving down life expectancy. This is a conscious choice of our political class. But it won't just be the poor and the sick who are the targets of all of this. In fact, the prime targets are the middle classes who are increasingly seeking to cover themselves to bypass the failings of the collapsing NHS, the engineered collapse of the NHS. And this is a graph from the Times, which shows what happened to the insurance premium of a relatively well-off middle-class barrister who developed an illness, a cancer diagnosis. And what they actually did was, over a period of 8 years, effectively priced him out of cover. So his premium went from 6,000 to, as you can see there, almost £164,000 per year. because insurance companies work out your premium for the year ahead based on how much you cost them in the last year and how much you're likely to cost them in the future. So unless you've got a very big nest egg, most people, if they become sick and expensive, will be priced out of care. The problem is none of them realize that they'll be dumped back on the NHS. So at the moment, they're largely ignorant and sitting there maybe feeling some sense of security. We have collectively failed to reach out to that group because our interests are wholly aligned. So this was the barrister, James Guthrie, whose premiums were shown there. So why doesn't anybody know what's going on? Why don't people realize that this is a transnational corporate asset grab? And why don't any of the staff understand what's going on? Well, this is largely down to the health unions. The health unions signed up to an agreement back in 2006 when Patricia Hewitt was Secretary of State, called the Social Partnership Forum. And in effect, they said, we will not fight your privatization agenda. This is an article by Stuart Player, well worth reading. Another article refers to the Social Partnership Forum, which was re-signed in 2021, called the Transition Partnership Group, which in effect said, we will facilitate your shift to the American-style integrated care system, and we will provide no barrier to this. So this is why there is close to zero public awareness of what has gone on. A massive travesty, a stealing, a raiding, a corporate raiding of the most treasured public service. And these are some of the offenders highlighted here, including Unite, GMB, the British Medical Association, and the RCN, and others. So I'll bring this down to the sort of things that I'm facing on an increasingly regular basis. This is based on a patient of mine. It's a few 2 or 3 years ago. She was in her 60s. She was known to have severe circulatory problems. She wasn't getting enough blood to her legs, and she required bypass surgery for that. And she developed severe abdominal pain, went to the local urgent care center, which used to be a hospital, used to have a fully functioning A&E department, used to have surgical beds, acute surgery, an intensive care unit. All of that had been stripped. And now she went to a privately run urgent care center. Half of the hospital site had been turned into luxury retirement homes. She saw a junior person, it's not clear whether this was a PA or a junior doctor, who, being an urgent care center, didn't really have any senior colleagues to speak to discuss the patient with, and unfortunately made a misdiagnosis, failed to recognize what was going on, and instructed the patient's husband to take her to the nearest hospital, which is about a half an hour away. The wife collapsed in the car. An ambulance had to be called. She was close to death. She was rushed to the nearest A&E department, from where she was yet again transferred to a tertiary hospital. By this time, significant time had elapsed when she was diagnosed with a ruptured aortic aneurysm. Now, the reason that's important is somebody with known vascular disease presenting with abdominal pain, an aneurysm should be quite high on the list of diagnoses of a doctor, if not a junior doctor, his senior colleague. But in this situation, that protection, those layers of protection, those slices of Swiss cheese have been removed. So eventually this lady ends up, I believe it was in King's College Hospital, London, where she had extensive surgery, barely survived, required multiple operations to rescue her bowel, which had become deprived of oxygen and her bowel had died. They had to leave her abdomen open because there were so many interventions required. She languished on the intensive care unit, which is a very expensive place to be in the hospital, for up to a year, at which point she died. Now, if this is the efficiency that all these privatizations are supposed to bring to us, then I'm yet to be convinced. Now, I was going to show a clip of Julian Assange. He makes an analogy. He makes a case that the war in Afghanistan was never designed to achieve anything for the local population. It was never there to instill Western-style democracy, for what it's worth. The whole agenda was to use the war as a way of producing arms for arms manufacturers, and then the American taxpayer funding the sale of arms to Afghanistan or providing those arms, and those profits from those sales coming back to Washington and those corporations. So he described it as a massive tax-funded laundering operation for the military-industrial complex. Well, I put it to you, that is what our NHS has become. It is no longer there to have healthy people living fruitful, productive, pain-free lives. It is there to serve the insurance companies, the drug companies, and various other outsourcing companies so that they can maximize profit. And if people do get a bit of health intervention that benefits them, well, that's secondary. The primary purpose is to siphon as much of the tax money that goes into healthcare away from the delivery and into the pockets of shareholders and chief executives. So my key points is to say, look, NHS privatization is not some future threat. It's already happened. The NHS is now a corporate cash cow. The waste is endemic, estimated to be in excess of 20%, just running the whole privatized charade. And a lot of money is being sucked out through profiteering, outsourcing contracts, and the purchasing of IT systems and hardware, which is not done in a best value for money, which would be done as the NHS as a whole, purchasing as an oligopoly with very high purchasing power, the ability to drive down prices. We have a fragmented morass where actually they're paying through the teeth, through new kit and through IT solutions, which are nothing. They're not solutions. They are yet another opportunity for companies to divert money away from healthcare. IT cannot replace doctors and nurses and healthcare professionals delivering care, but that is the fairy tale we are being told. This has only been able to happen because we have a media and political establishment that keep us in the dark, misdirect us, brainwash us with narratives around more funding and an aging population and scapegoating the sick and the poor and everybody else, whilst they raid our public services. Unfortunately, our unions are laying on their backs, doing very little. Our regulators are complicit, such as the General Medical Council, which has rubber-stamped the inclusion of non-doctor substitutes into the medical register, thereby creating confusion amongst the public and blurring the boundaries, whilst failing to set quality standards for them. And not to forget that, upwards of 90% of the population will be worse off. There is a very small cohort of people who are going to be financially and professionally advanced, serving this corporate interest. What we need to do is a clear call for renationalization. We need to have a narrative that explains that this is not an issue of one politician versus another. There's a bigger agenda at foot. This is a transnational asset grab fronted by the banks, the financial institutions, and various other organizations. Our government is just letting all this happen. Ultimately, a lot of what we're dealing with in the NHS, if we had a decent food system, if we had a lot of concentration on prevention, it isn't inevitable that we'll be spending more and more money on healthcare. For example, if people had a living wage and could eat decent food and had job security, well, that would prevent a lot of the people I'm seeing who are now sick as a result of junk food and high levels of stress and uncertainty and insecurity in their lives. These are economic policies which are causing detriment to health. And there are a few groups, including this one, which I've worked with and recommend people look into, and there are lots of resources on the website associated with the film. And I'll stop there. Thank you very much.
Thanks, Bob. That was excellent. Thank you so much for that. And I think you've clearly shown how all the principles 1, 2, and 12, 1, to nationalise services, basically reinstate the welfare state, which is being systematically dismantled, 2, to provide a national health service, and 3, to transform the economic system so it works for the majority of us and not just corporate interests, have all been demonstrated in that talk you've just given. So thank you very much. And also the elephant in the room that people just don't know about it. Thanks, Bob. We've now got some Vox Pops with Bob and me and Susan when we went to protest outside the Royal College of Physicians in London. Thanks, Ali.
So we're here outside the Royal College of Physicians handing out leaflets to doctors. So how has that gone so far, Mary?
Well, of the people we've spoken to, on the whole, they're very supportive, and they say that we're talking to the converted and they agree with us. So the proposition we were putting to them is that they should question the creation of the role of physician associate in the first place, rather than get sidetracked on defining the scope. And most of them have agreed with us so far.
Did they seem to understand the agenda of privatisation, Susan, do you think?
I'm not convinced that all did. I think some of them see it that it's like a fait accompli, and that really what you need to do is just rationalise the role and oversee the management of it. They've also admitted that there's a cost implication, that they see the physician associate as being a cheaper option to employing an actual qualified doctor, and that concerns me. So what you're then doing is determining person's health outcomes or based on profits for private healthcare companies which are coming into the NHS.
And how does a doctor substitution help the privatisation, Mary?
Because these people are less qualified, so they are cheaper to train. And if you are a private provider within the NHS, then you're looking to cut corners to maximise costs, to reduce your overheads, then it's cheaper to employ a physician's associate than a fully qualified doctor. It's not cheaper in terms of patient safety and people's lives, but it's cheaper on a balance sheet to employ those people.
And probably in due course, once they've got rid of the doctors, they'll start to screw down the wages of the PAs as well. Would you agree?
Yeah, because once you force the doctors out, and that seems to be everything that seems to be happening at the moment, is a nudge to push doctors to leave or just leave them unemployed. They can't get, there's thousands of unemployed doctors. Then once there are no doctors and we've got no other alternative, these companies can then push down the costs and keep wages low and maximise their profit.
And ultimately, they will be allowed now into these new integrated care systems to make profit by squeezing the wage bill and denial of care. And what does that recipe spell for patients?
Well, it's dangerous for patients. It's also dangerous for the staff because, you know, those private providers and the trusts, are they going to stand by these physicians associates when it
Thanks. Thanks, Ali. So we've now got our second speaker, Nico Chergo. He's an NHS activist. His topics are on why Principle 2 and that Principles 1, 2 and 12 of For the Many Network are linked, why public ownership is so important, reframing the NHS narrative for the left, and why is public service the core healthcare issue, resisting constant attempts to change the subject. Thanks, Nicholas.
Okay, can you hear me, by the way? I'm testing these headphones.
Yes.
I have to be on a phone. Okay, great. So, yeah, I am going to be thinking about the left narrative that's not weighed down by Labour's recent decades on the wrong side of NHS policy, referring to this principle number 2 of the network that's up on the screen. I'm going to defend for what purpose renationalisation was and remains the core practical and political point to make for healthcare, as Bob alluded to. So in doing that, I'll also look at the narrative designed to divert us away from the public-private dynamic and talk about other things. Some of the slides may look a bit old, but the point is they're about long-term policy that's still ongoing and that's been left out of official narratives, and that we shouldn't leave out is what I'm seeking to communicate. So to begin with, if we can flip to the next slide, just to visualize the basic policy principle, the principle around which policy revolves is basically that any policy to expand private healthcare, if you want to press play on that, necessarily means shrinking back the only entity that can provide all our healthcare to all of us, which is the state, providing an NHS, unshackled by whether it's profitable to do so or not. So you lose that unique ability. The reason that all healthcare had to be nationalized in the first place is so as to be able to give all our communities, rich or poor, the whole range of care, from a general practice with an actual GP, not a fake one, to a general hospital, including an actual A&E, a consultant-led maternity, all those things that are being taken away. And just next slide, please. And yeah, that's when, so we see it in both directions. It flips both ways, basically, that's the point. But you increase the role of the private sector, that means decreasing the role of the public sector, which is the one that can do everything. And it means cuts, closures, downgrades, the ones that we're talking about. That's, I feel, a useful way to look at it. Can we see the next one? And hopefully we've got sound on that. And if we don't, we might need to check the sound. Move the next one to the next slide, please. The next slide. That's here we are.
Every hospital in this country will be nationalized. I will build more hospitals, better hospitals, where there is need rather than where there is money.
So our narratives should not budge from the downgrades, cuts and closure policies that are targeting Bevan's achievement, and current policies particularly focused on destroying the general hospital. So he'd have it frozen on his face like that. That's an amazing performance if anyone gets to see it. Because it's those cuts, closures and downgrades that are what creates the opening for privatization. And it's those policies, those specific policies that emanate from NHS England that need to be called out by name. And that's what's been missing. It's just, there's a lot of acting as if they don't exist. I want to, can we pass on to the next slide, for Michael Sheen?
Every hospital in this country.
Next one. And so this is an example of policy. So it's as affects, and Bob talked about this in passing as well. It's the policy affecting the policy to close and downgrade A&Es, and why it's happening. To press play, this is, we had 144 A&Es 10 years ago, but sorry, A&E hospitals, and
shrinking the 144 A&E hospitals we had in 2013-14.
We're working with commissioners and with hospitals across the country to designate 40 to 70 major emergency centres.
Label 70 to 100 smaller A&Es as emergency centres that deal with less serious conditions.
They say the changes are temporary,
But for the people of Chorley, the closure of their accident and emergency unit at 8 o'clock this morning will mean a journey of at least 20 minutes. Minutes former patient Jessica Knight didn't have when she was rushed there with multiple stab wounds 8 years ago.
Charing Cross A&E to be replaced with an emergency centre run by GPs and nurses.
Both Hammersmith and Central Middlesex hospitals have GP-led urgent care centres on site.
Urgent care clinics have become a $14 billion business.
We'd always wanted to break into the urgent care market because we knew that that's a growing area of outsourcing for the NHS.
So it's a conveyor belt. I hope you can see it. You have national policy that's closing the comprehensive local services, in this case A&Es, to extract just the profitable bit, the minor injuries in this case, for private healthcare. If you have a serious accident nearby, it's not going to reassure you to hear that we no longer need these services because of an aging population, or blaming so-called demand for the cuts, which these are the narratives that we hear most of the time, including among the left, a lot of the left, because we didn't have a lead on the left. We had right-wingers in Shadow Health on the Jeremy who could not possibly have opposed this. And we'll look a little bit at that and how that has limited what we're talking about, and we need to be free of that. So going back to principle 2, this dismantling that we've seen an example of, it isn't the outsourcing in itself, which is mentioned in principle 2, and it isn't a funding issue either, which is mentioned there. It's something else which isn't mentioned there. I'm not saying you have to mention everything, but it's something else to be reversed. And it is something to talk about, to make it real in people's political imagination. It's the national policy program to destroy services for profit, whether it's called the NHS England's long-term plan, the ICS's, it's those policies emanating from NHS England that need to be talked about as something more than that policies that require more funding and more staff. They are policies to reverse. So is it possible to oppose those policies politically? Yes, we're not invited to do that in general, but we did do that, significantly protested this kind of restructuring in the 2000s, and also in the brief time Diane Abbott ran Shadow Health on the Jeremy. So why not now? And to see the narrative battle that there has been from a position of opposition among those in the opposition, I want to contrast Diane Abbott's opposition to this policy program with the Labour Right's constant support. So the next clip, please, of Jeremy's first Shadow Health Secretary, Heidi Alexander, when she was confronted with this program of destruction.
Labour's been very supportive of the 5-year full review. That involves some transformation in the way services are provided and where they're provided. You, in a sense, partly made your name, Heidi, by the campaign over Lewisham's A&E and plans to downgrade that and maternity services. Some of the transformation stuff will see services move, services close, services shift.
We can't preserve the NHS in aspect. We need to look at how we use NHS assets better. There's a whole list of land and buildings that is supposedly surplus to requirements. So let's use the estate, the NHS estate, differently, and let's craft a story and a narrative in which the public can believe and where we can bring them along with us.
Okay, so what have we just watched? We see a Shadow Health Secretary whose job you might imagine as holding the government to account, reacting instead to a government closure program by saying, let's lie about this to protect the government from public scrutiny. That's her story and her narrative. This is real. It's a real phenomenon. It's not just imaginary. There's a definite effort, a consistent effort from a position of opposition or neutrality, such think tanks such as the King's Fund, the Nuffield Trust, that are generally useful for data, but run by corporates and ex-Blair advisors who went to the US to copy their system, like Chris Ham. Those come out. It sounds like a criticism, and they're asking for more funding, but they're asking more funding for these policies. And so we need to ask if we can. Do we have to agree with that, or can we instead oppose the policies outright? So to show that it can be done, there's Diane Abbott during the chicken coup. She was briefly Shadow Health Secretary, and that's when we heard what opposition sounds like. The same policies she talked about existed before and continue today. They have different names: 5-year forward view, sustainability and transformation plans, ICSs. It's the same policy process. brought to us by a fake NHS, the 2012 Quango that calls itself NHS England. And in talking about narrative, part of the rights narrative is to present our assailants as our friends. It feels only natural that a fake NHS is also swapping our real doctors and nurses for fake ones. So can we see the next one, please?
Labour's been very supportive of them.
And play.
And now a word about the increasing private sector involvement in the NHS. It is the NHS England's Director of STPs, Michael McDonnell, who has said they offer the private sector and third sector organisations an enormous amount of opportunity.
And the next one.
And now, increased reliance on volunteers and the downgrading of treatment by skills, responsibilities and pay bands.
So she's calling out the downskilling of staff, which is what we're seeing more of now with the physician associates. And so it was perfectly possible to call this out and to oppose it in Parliament and to say no to it. Whether or not the government called the debate on it, she called this debate. So it's a choice. There is a choice being made by people like on the right not to talk about it, but we should not make that same choice. We should recognize there is a policy program and speak about it. And next slide, please, as well. So here we have, you know, a quote from John Ashworth when he became Shadow Health Secretary, and he spoke of the same policies that she opposed as something that we need to properly fund so they can meet changing demands on NHS services. That was totally supportive of it. And I'll argue that in this context, Ashworth was not innocent in deciding to make funding and not privatization the main issue, because as it's worded here, its main semantic function has to be understood in the context of that destructive program, and it served to signal Labour support. He meant more funding for the fake NHS, NHS England Quango, and its program of dismantling the real NHS. And I'm also saying that given the damaged services, we are morally obliged to take sides between the two opposite positions. The next slide, please. Oops. And so this is by contrast. Diane called the same policy program under that same branding, STPs, a dagger pointed at the heart of the NHS. She's not saying it needs more funding to function. It's saying we need to stop it. So it can be done. So in conclusion, the reason why we have to fight so hard to break the silence on the anti-NHS policies is that the Labour's Alan Milburn era long-term commitment to destroying services for profit continued after 2010. Central to it is Labour's role in copying US government incentives to cut back services that Bob has talked about, the HMOs, ICSs, incentives to cut back services which created the unjust system in the US and finally became English law in 2022. So look here now at one of the many US policymakers who've been invited to the UK over the years to teach us to copy their system. It's the ex-director of the Veterans Affairs Government Health Service Program telling us where that system likes to cut. And the next one, please, and play.
If one really focuses on and achieves integrated care, there will be a need to restructure one's assets. This is perhaps code for meaning less hospital capacity. In many communities, hospitals are sources of identity, community identity. And when they lose their hospital, they feel like they lose their vitality. And so in thinking about this restructuring, we have to be mindful that there are other roles of hospitals than just healthcare.
So this is a context for the hospital closures in the UK that you don't hear, because you hear that there are local decisions. You hear that there's because there's not enough demand or there's not enough staff and so on and so on. But this is the policy context for that. And you ask, why cut hospitals in particular? Why focus on that? Why does this system we're calling integrated care focus on cutting those? Could you put the next slide, please, and play?
If one really focuses on and achieves integrated care.
A big shift in healthcare is moving from acute care hospitals and inpatient care into the home and the community setting.
Particularly in the community, the health service now faces competition from the private sector.
In hospitals, private firms have won contracts that amount to 4% of what's spent overall. But there's been a rapid rise in private companies providing community healthcare. 18% of these services are now delivered by contractors on behalf of the NHS. And whoever delivers these new models of healthcare, transforming the way the NHS works, is going to be tough.
So this has got by a lot of people on the basis that moving services into the community sounds wonderful and must be a great thing and requires more funding. But this is what it's doing, and this is why it's happening, because there are opportunities there that you don't have in a general hospital that mixes up the profitable with the unprofitable, because it's based on need. And I'm gonna have another clip now from another US policymaker around the time of Obamacare and the England's 2012 Act. He's describing these incentives, these financial incentives to cut back services. And we can see it's a system that was rolled out from 10 years ago. It was begun to be rolled out nationally with the backing of all the major parties. Please press play.
Accountable care organization is a core reform in the healthcare reform legislation. And it attempts to get at what is really more accurately called an opportunity for shared savings, to get them to participate in this change in culture, change in attitude towards service, trying to reduce the numbers of services, or at least make them reduce the unnecessary services, and to make sure that they participate in the benefits that are generated by that reduction in the level of service. And that means that the pain of reducing the volume of services, which is important to reducing inefficiency, that pain is mitigated and potentially turned into a gain. So is it transferable? I think it could be transferable. I think it is a solution to a problem common to all modern healthcare systems, which is how to be efficient.
NHS will therefore take the first steps towards true population health commissioning, with care provided by accountable care organisations.
Accountable care organisations. They are policies developed by this side of the house.
So this is where we were before Jeremy became leaders, and West Streeting hasn't fallen on us from the sky. It's continuity, and just a bit louder about what they were already doing and insisted on doing even while Jeremy was leader. So that the importance of understanding that, to me, is about how what's supposed to have a democracy where you have parties calling each other out, but they all agree on this, and so we don't get a democratic debate about it, and we don't get those policies called out, which is where the left comes in calling them out. So again, we have to consistently call out those long-term US copied dismantlement policies and build that story in people's heads as a real thing, because it is a real thing, and that's how narratives work. And so, although the point of the system we've copied is to reward the cutting back of our essential services, it's been misrepresented to us again and again as a benign effort to bring health and social care together in the public interest. So I would be very, very wary of that narrative. And another slide, please, and play.
Accountable care organization.
If we look to the US, the best providers are working on that highly integrated whole person basis, coordinating physical, mental, and social care.
The goal is to coordinate care and eliminate unnecessary spending. What's in it for the ACOs? ACOs that save Medicare money get to keep a portion of that saving.
We have got to take the best of that approach and universalize it here.
And sadly, that's what's happened under Conservative governments, with heavy participation of Tony Blair advisors running the health policy, and with support from shadow teams that should have been opposition from a lot of that time. So because of that narrative, again, I have to caution against automatically coupling health with social care as in principle number 2, because that's what it's a euphemism for. It's a euphemism for this US system to destroy our health service. Instead, I bracket the need for healthcare renationalization to restore Bevan's unsurpassed redistribution of healthcare squarely within the need to restore all the former public services in the welfare state, as Mary mentioned. And in fact, addressing the public, I'd even define the core differences between the major parties and the left alternatives as their long-term commitment to finishing off the welfare state, that's people's services, versus our determination to bring it back. It isn't privatization within our NHS. It's not bringing down waiting lists. It's plain old policies to get rid of people's basic rights, including health. Okay, I hope that was helpful and audible. And that's me.
Thank you, Nicholas. Again, another excellent contribution. I think we're hearing a theme cutting across our speakers tonight of across party consensus to replace the NHS with Americanized systems designed to deny us care, benefit big business, and the fact that they do this by not mentioning the elephant in the room, telling us all sorts of different reasons why we're being denied care, why our doctors are being replaced, why our hospitals are being closed, such as blaming the elderly for bed blocking, rather than talking about the policies. Thanks for that, Nicholas. That was excellent. I think we have some vox pops now of members of Merseyside Pensioners Association, just before we take our next speaker. Jude, what do you think about replacing doctors with physician associates?
Disgraceful. People are going to the doctor and they think they're seeing a doctor and they haven't even been informed that these physicians associates are seeing them. You know, I wonder, you know, I'm not quite sure myself about these physicians associates. Can they prescribe? Are they supposed to prescribe? Well, I've had something prescribed to me by a physician's associate. Find it disgraceful.
The prescriptions they want to give you have to get signed off by a doctor.
Right.
So hopefully they did go and speak to a supervising doctor before they actually gave you the prescription. Thanks.
Okay, then.
Hi, Sheila. I was wondering, what do you think about replacing doctors with physicians associates?
I am very thanks for asking the question. It's so important, isn't it? How can you possibly throw away 10 years of training if someone else you trust and appreciate with your own health, with your own, with the life of your children, your mum or your dad, whoever said, I think it's absolutely disgusting. It's all about money, it's all about finances. You know, there used to be the saying, the people before profit. That's completely reversed now. There's profit before people, and that's all that it's about. It's about not people's health at all. I think it's awful. More people need to know about these things. So thank you for your speech, Mary.
Thanks, Sheila. What do you think about replacing doctors with physicians associates?
I just think it's a real cynical way of destroying our National Health Service. You know, it's a kidology involved. It's dishonest. It's not informing people what a physician associate actually is, and then they're not trained, they're not qualified doctors, you know, and they actually don't front up and say, actually, you know, I'm not a doctor, I'm only 2 years trained. And I think it's deceiving the public. I think they're keeping it very quiet. It's being brought in by stealth, and it's going to make, you know, we've got to pay. Everyone's worried about how I'm going to see a doctor, and so they say, well, hang on. You can have this, oh, it's a doctor. Well, actually, it isn't a doctor. And, you know, I think people have got to be made aware that it's very frightening that we're not getting the fully qualified people that we really need.
Thank you. Well, what do you think about replacing doctors with physicians associates?
Casualisation and de-skilling, not for the benefit of patients, for the benefit of all.
Thank you. Short and sweet. Thanks, Ali. Our next speaker is Leslie Mahmood from the Save Liverpool Women's Hospital campaign. Leslie is, well, going to give us a local perspective on the deliberate policies that Bob and Nicholas have talked about up to now, about the cuts, closures, downskilling, deregulation. So Leslie's going to speak about the Save Liverpool Women's Hospital campaign, maternity services cuts, and the integrated care system in Cheshire and Merseyside. Welcome, Leslie.
Okay, thanks, Mary. Good to see everybody. Yeah, we have, as we know, worsening health, worsening life expectancy, including a great decline amongst women. For instance, in Liverpool, women are going to have another 4 years of ill health, and they're going to live even shorter lives and in less good health. We've got nearly 8 million on waiting lists. We've got many people still suffering long COVID. We've got worsening mental health, especially and stress, especially at work and also amongst young people. And this is a time when we need a fully functioning NHS more than ever. We've got an increase of maternal deaths. We've got an increase of birth trauma. We've got an increase of stillbirth and neonatal deaths nationally. And we've never needed good maternity services more than ever. Now, as people have said, the NHS was the jewel in the crown of the welfare state. And locally, Liverpool Women's Hospital was the jewel in the crown for women's health on Merseyside and wider. And the fate of the Women's Hospital and the issues of maternity are totally tied up with the whole issue of what's going on in the NHS, and they reflect what's being done deliberately to the NHS, to maternity, to women's health, to mental health, dentistry, A&E, access to GPs, etc. And, you know, obviously others have spoken on some of those things. And the deliberate deconstruction of the NHS, which has been mentioned, started with Thatcher, and then we had Blair's New Labour with PFI and the mention of Simon Stevens. Now, Simon Stevens has, and the integrated care systems, these big American corporations were part of writing the whole Health and Care Act and the integrated care systems and the setup. And as has been said, he was running the biggest health insurance company in America, and he was brought in by Blair to run the NHS and oversaw the two health acts. Now, as has been said, this is an international thing as well, because Davos is, many of you may have heard, Davos is a place not just for skiing apparently, but where the rich, the super rich club, get together once a year, and they also bring their chosen representatives of the labour movement, like Starmer, to come and have a nice chat and a pat on the back from big business. And these acts were discussed at Davos as part of their international strategy for profit. And the introduction of the integrated care systems dramatically speeded up the deconstruction of the NHS and the denial of care. And I just want to give some examples about how that's worked out in Cheshire and Merseyside and for the Women's Hospital. So, for instance, in the Cheshire and Merseyside integrated care system, a third of the budget goes to private providers now. And those private providers just get an NHS sticker with the logo on and stick it over the door. But they're not the NHS in reality. We know that Labour under Starmer and Streeting have openly said we'll open the door to private providers in the pretence of reducing waiting lists. Now, locally, we have Spire and Spar Medica amongst several privateering culprits. They don't train NHS staff. You know, nationally, the NHS has 75,000 training places, and actually that's not enough. But the private sector provides less than 100, nationally provides less than 100 training places, and they can't provide proper training for NHS staff. But what they do is they pinch NHS staff, they cherry pick NHS treatments. So, for instance, as I said, Spar Medica and others in the Northwest now take 61% of NHS-funded cataract operations. Before COVID, they were doing 25% of NHS-funded cataract operations. So we can see the whole thing has been turned upside down as the cash cow. And of course, if you reduce training opportunities for junior doctors because you're doing fewer operations, you can't learn the complex stuff without doing the simple stuff first. And also, if you don't have the simple cases, they subsidise the more complex cases. So recently, one of the Better MPs Margaret Greenwood locally, who has spoken out on these systems and what's going on, has recently had a debate and to highlight this dangerous point of collapse, if you like, about eye care in the NHS locally and nationally. But locally, we had experience of a government initiative which was to be rolled out nationally. It was to have private provision of home births, and the plan originally was basically to push women out of hospital and to encourage more women to have home births. This private firm based on Merseyside, got contracts across Merseyside and the North West, but it actually went bankrupt overnight. Had a very nice office in Warrington, but it went bankrupt overnight, and the mothers and the staff were literally left high and dry, some women days before they were due to give birth. So guess what? The women's and other NHS hospitals had to pick up the pieces. And somehow that idea of women no longer giving birth in hospital and just doing it all at home with private midwives has kind of gone under the radar, and I'm not aware of many other places where that's happened. And one of the reasons is, if you set up a private company, obviously the motive is to make money and make profit. But maternity has actually for a long time not been fully funded properly. So the cost of actually maternity and giving birth, so antenatal care and postnatal care, and the cost of the birth itself isn't covered by something called the maternity tariff. So in other words, it actually costs more to give birth than the government pays the hospital. Now, many hospitals just cross-subsidise their local maternity unit to cover the shortfall. The Women's Hospital, 80% of its income is from the maternity tariff. And of course, the reason why the Women's Hospital was picked out in 2015 was part of this foreclosure, was part of this move to get rid of the smaller hospitals and to amalgamate and have these super mega hospitals, which were basically going to push patients out the door in as many different ways as possible. And the other thing that's happened is, of course, as the NHS has been cut and destroyed, as burnout and stress has increased during COVID and after, and staff have been for years undervalued and underpaid, then many midwives, like other NHS staff, have left. So the Women's Hospital, like maternity nationally, has seen a shortage of midwives and other staff. And nationally, there's over 2,500 midwife vacancies. The older, more experienced midwives and staff are leaving and being replaced with newly qualified midwives. Now, good that people want to become midwives, but if 5 experienced midwives with 20 years service each leave, that's 100 years experience. If you replace them with 5 newly qualified midwives, that's only 10 to 15 years experience. And that's what the service is losing by the deliberate demoralisation and undervaluing of staff. That's all part of this reorganisation of the NHS. And what a scandal that the NHS in 2021 to 22 spent twice as much on maternity legal claims than the whole of spending on maternity and neonatal services. So in other words, the government is prepared to let women and babies be injured or die rather than actually reorganise services on the Bevan lines and fully fund the services and pay the staff. Now, there's been another report out this week on birth trauma, and sadly, that's just one of a whole series of reports. We've seen scandal after scandal at many maternity units. The CQC reckon that 38% of maternity units need improvement. Now, this woman, Donna Ockenden, a very senior midwife, has done independent reports about the scandals, including Telford and Shrewsbury, East Kent, and she's working to produce a report about Nottingham, where numbers of women and babies have died and been injured. And that has been ignored by the trust boards, because sometimes the reputation, it's easier to ignore the staff, it's easier to ignore the patients, it's easier to ignore the families than actually raise what the issues are. And she's identified that shortage of staff, cuts in funding, women, midwives and staff not being listened to have meant very poor outcomes, including deaths. And also there's worse deaths and outcomes for Black and brown women giving birth and Black and brown babies. And the Women's Hospital itself last year had 2 terrible deaths of Black African women. One was actually described by someone, we don't know who said it, but was described as being difficult when she was in excruciating pain, and she died later. That and a poor CQC report was a bit of a wake-up call, I think, for the Women's Hospital Board to increase the numbers of maternity staff and to actually say that they've got to set up an improvement plan of 2.5 million. Now, we're totally in favour of that, but obviously it doesn't solve the problem. But I just want to tell you what that 2.5 million they want to spend it on. A 24/7 medical emergency team, 24/7 obstetric consultant cover, 24/7 blood bank and blood transfusion unit on site. And you need to ask yourself, why weren't those things actually provided? Why does it take a crisis to decide that you need those things when babies are generally born in the middle of the night? Giving birth can cause you to bleed out, and you need senior cover, because the Women's Hospital especially takes many complex cases. So why is this something that's seen as revolutionary? Now, we support those things being brought in, but I would have thought they're the basics, and we've been arguing for those. But there has been 18 million spent on a brand new neonatal unit and scanning and facilities. But the madness of the integrated care system means that the integrated care system is trying to say they've got these deficits, and therefore all the hospital trusts have got to have a 5% cut across the board. And the Women's Hospital, which is already underfunded, understaffed, etc., has argued that they should only have a 3% cut. And to me, that's a bit like saying, can you just cut me wrist a bit slowly rather than going for the jugular across my throat? In 2015, the decision makers, it was the head of the decision-making body locally at the time was called the CCG. And the chair of that went on the television and said a hospital in Liverpool has got to close. And the next day, the Liverpool Echo was pointing the finger at the Women's Hospital. And again, say this is all part of that pattern of close the smaller hospitals down. No matter that they do, world-class research, do everything from repairing female genital mutilation, genetic treatments, right through from before life to end of life. They wanted to close the Women's Hospital, and that's when our campaign started. Now, the Women's Hospital Board used to talk about, we need a lovely brand new hospital on the site of the Royal Hospital in Liverpool. Now, that's a mile down the road. The difference is the Women's Hospital is a lovely green site. It has grass. It has trees. How many modern hospitals have things like that? It's peaceful, it's tranquil, it's low rise, it's easy to park. These are all really important things. The local community, which is very mixed, a huge ethnic mix, are really passionate about the Women's Hospital, and they feel it's safe for their community. They don't want to go to town. They don't want to go to the mayhem. didn't want to go to the mayhem of the old Royal, and they certainly don't want to go to the mayhem of the new Royal. And again, just to show the effect of the policies that have taken place, the old Royal needed to be replaced. It was a mess. It was becoming a slum. But the powers that be, the Tories, etc., and the local decision makers, against the advice of local campaigners, insisted that this had to be done under PFI. And so the new Royal was built with PFI, and Carillion, the builders, they took their shareholders' profits and then declared themselves bankrupt. They went bust and they left serious structural faults. And of course, the government then had to step in and put the things right. No women's services, by the way, were ever planned there. But despite the warnings, the PFI was planned with 300 fewer beds. And the excuse, as we've seen on the films, will have more services in the community. And of course, the result is that the Royal A&E, this new A&E, is one of the most crowded. It's too small. It's constantly overflowing. If you're lucky, you might get up one floor to get in the corridor for corridor care. And again, despite the best efforts of staff, as with many staff in the NHS, with the closure of beds, wards, hospitals, A&Es, it's all about denial of care. So we knew 9 years ago that a new hospital wasn't going to be on the cards. Now, Boris Johnson, one of his ready-made, oven-ready solutions was supposedly 40 new hospitals. Now, we knew that that was never going to materialise. And just one example, Leeds were promised a new children's hospital, and they did need one. The old building was actually demolished, but since they have been campaigning, and now they've been told they're going to get a new unit or a wing added on somewhere sometime in the 2030s. And that's why we are fighting to keep the Women's Hospital on site. We do not want a scout hut for women in the corner of the Royal for the women's. Now, the new chief exec has finally admitted that there won't be a shiny new building in the next 5 to 10 years, but also we don't want the maternity and women's health services at the back door either. And of course, if you start shifting things around, they're all talking about we're looking for solutions across the integrated care system. Once you start spreading services out, it's easy to close a ward, it's easy to close a clinic. It's a bit more difficult to close an actual physical hospital. And of course, the shortage of midwives and consultants, etc., is not anaesthetists, is not going to be solved by physician associates, as others have said. There's even talk about associate midwives. Now, at the moment, not at the Women's Hospital, but nationally. But in America, they actually do have midwife associates, not midwives, so midwife associates. And of course, we know that's not the answer. The other thing in this parliamentary report is they've said, oh, we could have a birth czar to deal with birth trauma. Well, that's not the answer. The answer, as everyone has said, is the whole structure of the NHS and the fact that the Bevan model is being destroyed. And it's no substitute for, along with the rest of the NHS, a fully qualified, fully trained, properly paid, fully funded, publicly run and publicly provided maternity and women's services, and a return to the Bevan model. Now, we know, as others have said, the Tory, Labour and popular press are all chorusing, the NHS is no longer fit for purpose, and our reply is, bring back the Bevan model. And the clip from Nico, if you haven't seen it, I would highly recommend the Nye Bevan film. But it shows in 1948, despite obstacles and on a tight timetable, you could have a nationalised health system, and it became a world-beating system for decades. But I would also say that it wasn't just Nye Bevan, there was a movement under Nye Bevan. There was a huge demand from below, including by many women, including working class women's organisations at the time, like the Women's Cooperative Guild, whole sections of the trade unions, like the miners and their local communities. You had people returning from World War II after the austerity of the 30s, and they demanded something better than paying for piecemeal, haphazard services. And the NHS had its 20-year plan to start off with, from cradle to grave, to distribute free healthcare to everybody, no matter where you lived. And the result was a huge increase in life expectancy, a huge improvement in general health, a huge improvement in women's health, a huge drop in maternal and infant deaths. And of course, we've seen today, after decades of attacking the welfare state, we've seen the return, the decline of health, and the return of maiming women and babies and deaths. So we do need to reinstate the nationalised NHS and scrap all the privatisation and the ICS systems. And just towards the end, I just want to say two things. One, about how we're going to do it and what we can do. We do need to work together to build a mass movement that demands this NHS back. Now, we need to recognise that the deliberate wrecking of the Corbyn movement was a major setback. That was done by all the allies of capitalism, and we know the role of Starmer and Starmer's Labour. The public do know there's something wrong with the NHS. The narrative is clouded. They don't know what's really gone on. But what we need to do is have that conversation in the street, in the workplace, in the community, to explain there is that major fight between the major corporations and the interests of big business, and why we need to campaign for the health service. Those lobby groups and those mega corporations who also pay Starmer, Streeting and other people in the Labour Party are after £283 billion of government funding in this country for healthcare. That's the prize. And when they say, oh, we can't really afford the NHS like it used to be, well, we know that's a load of tosh. We are the 6th richest country in the world still, and we can afford free healthcare for everybody, including paying for the training of the staff, reintroducing bursaries, scrapping migrant charges, etc. So what can we do?
So, Leslie, I'm really sorry, but we've gone quite over our time, and Jeremy Corbyn has joined the call.
Oh, okay. All right. So I'll just finish on this. I'll just finish on this sentence. I won't keep Jeremy, but we need to get out on the street. We need to explain. We've been round everywhere, every community activity, trade union event, picket, etc., to have these conversations, to explain to people we can do something. We can reinstate the NHS. And I would say particularly anybody here who's particularly interested in maternity, campaigning on maternity, or has got issues going on locally on maternity, please get in touch with Save Liverpool Women's Hospital as well. Thank you.
Thanks, Leslie. That was excellent. Thank you very much, and shows that these national policies have really serious implications locally, and that life expectancy is falling. And I'm really sorry that we've run over, but I think that we're now really pleased, and it gives me great pleasure to introduce Jeremy Corbyn, and that's something I never thought I'd get to do. So Jeremy Corbyn, MP for Islington, welcome, and it's lovely to have you here.
Thank you, Mary. It's a pleasure to be on. I'm sorry it's all been a bit late because I'm at a NACBAR event at the moment, and I've got to speak at another meeting in a few minutes as well. I just listened to what Leslie said and absolutely agree with her. And the campaigning that's been done to save the Liverpool Women's Hospital and all other hospitals around the country has been incredible. My own constituency, we saved the Whittington Hospital 10 years ago from closure, and we are absolutely on it the whole time to defend and extend our hospital. And the issues are that our NHS is under the deepest threat it's ever been. You might remember during the 2019 election, I confronted Boris Johnson with the truth that he had introduced a secret negotiations with the USA into opening up our health market to American companies. He denied it. They told me it was a Russian plot and that I shouldn't even be worried about it, and the NHS was safe. Within a few weeks of the election, the US healthcare companies had already taken over 50 GP practices around the country and are still trying to take over more and more. They are making a huge profit out of running GP practices in the same way that the privatization of various hospital departments, including the pharmacists, have made huge profits for the private sector. The internal market not just enables this, it absolutely encourages it, as does the 2012 Health and Social Care Act. And the profits being made out of our NHS by Big Pharma, the profits made are absolutely enormous. And the private medical sector, which is also doing financially very well, relies entirely on the NHS and public sector for its training and its ability to even provide some kind of limited service that it does. And so our demand is obviously for defence of the National Health Service, and that is what we're going to do. But it's also about the public ownership of the National Health Service. That means complete public ownership so that all staff are employed by the NHS, and the NHS is a totally publicly funded body. Otherwise, the cuts will continue. The influence of the private medical sector in trying to influence politicians by donations to election campaigns, and the effect will be to make the NHS into a service of last resort, not the port of first call. And they know that, and they will then create a bigger and bigger market for the private health sector. Any of you listen to daytime radio will know all day long there's adverts for how to buy your way past a hospital queue, and desperate people who are desperate to get treatment do that. That further undermines the National Health Service. So when the election comes, and it won't be long away, ask every single candidate, what are you going to do? Are you going to vote in Parliament to ensure the NHS is fully publicly owned and publicly run? Or are you going to allow this continual destruction of our health service? And while you're about it, will you also commit to having a care service free at the point of need that will provide care for all those that need it? It is the biggest cost to local government at the present time, and the biggest cost to many families. And it's mainly women who lose their jobs and their careers in order to care for people who ought to be cared for at the public expense, in the sense that it should be a human right. Those, I think, are the basic demands we have to make. We won the NHS in the first place because of determination and principle. We've defended the NHS because of popular campaigning. Now is the time to assert stronger than ever the need for a universal, totally free National Health Service, and alongside it, a care service. Thank you very much.
Thank you so much, Jeremy. That was excellent. And as you say, I think that's part of what we've been trying to say tonight. Ask every candidate who stands in an election what their policies are, and don't let them just get away with saying, I support the NHS, I oppose privatisation. We need to know what they understand by that. And hopefully tonight's meeting has given the attendees, has made them better equipped to be able to challenge candidates and ask those very questions. And thank you so much for joining us. It's every time I see you, I go speechless. I can't say anything. Sorry.
Thank you very much. It's my pleasure to be on the call.
Thank you. And so now I do apologise for us going over, and we haven't covered social care in this meeting, and I think it's too big an issue to, and it's separate to the NHS, and I think that we will organise another meeting to talk about social care specifically. If people will allow now, I'll just quickly ask our speakers just to say one line if they want to just add anything. If Bob is still there, if you would like to just sum up, just give us a a final word. Thank you.
Yes, still here. So it's been a great meeting. I think hopefully the audience are more confident in challenging the spin and feel more informed in terms of developing a comprehensive, easy to follow narrative, which is we do not want corporations stealing our assets, and we have to unite to regain what we've lost. So thank you all, and good luck to you all.
Thank you, Bob. Thanks for giving up your time tonight. And I would encourage everyone to watch Bob's film, The Great NHS Heist. It's excellent. Nicholas, if you, I can't see on your screen, if you're still there, would you like to give any last comment?
Yes, hi, and hi, Jeremy. I want to comment that if we're going to defend our local hospitals, it is not going to be enough to treat them as local issues because they are part of a national policy. That national policy is not the 1990 Act. It isn't the 2012 Act. It's a policy that began from 2014 under Simon Steve's restructuring, which was kept deliberately out of public debate. The only time it was brought into debate was when Diane Abbott confronted it as sustainability and transformation plans. Those plans under other names existed before, and they continue to close services nationally today while providing excuses to the local population for doing that and not mentioning it's a national program. If we don't confront the nature of the beast, which needs to be understood and is actual US policy, we are not going to be able to properly defend that. And I hope and expect that there will be a resurgence of activism as there was on the New Labour, but we do have to up our game beyond where it is now. Just one last thing, I have the emails from the Islington Keep NHS Public, and they say the local ICB, and they describe it as a body providing local services. It isn't. It's a local body. It's a body created to close services, and it's rewarded for doing so financially, and that's a mistake. So we do need to change that and recover what Diane Abbott proposed, because it still needs opposing today. Thank you.
Thank you, Nicholas. And Leslie, I'm so sorry to cut you off before. Do you have any final comment to make?
Yeah, we need back to Bevan. We need to kick out the privateers, kick out the integrated care system, renationalise the NHS. And I'm proud to say that Diane Abbott did come and speak at one of our Save Liverpool Women's Hospital demonstrations, and she's shown that she's kept to her principles. But we need to get that message out on the street and wherever we can. And I think there will be a revival of confidence, if you like. I think Palestine has been a lightning rod to get young people involved and more aware about things, and hopefully that can be turned into the NHS is still up there as one of the biggest issues for the general election. And as you say, we need to ask all the candidates and get them to commit. No NHS nationalisation, no vote, no ceasefire, no vote.
Thank you, Leslie. And Ian, sorry, I didn't ask Ian. Do you have any final comments to make, Ian Hodson? I've lost him. Sorry, probably wasn't expecting me to ask.
I wasn't. No, just
Sorry.
questions. Thank you for all the speakers, and obviously, please join us for our next webinar, which we should be holding soon. And well done to everybody who's contributed. Thank you very much.
Thank you. And so do we need the summary of our webinar slide? Thank you. Yeah, so I just wanted to thank everyone for speaking tonight. It was an excellent meeting, and I hope that attendees think the same. If you have any questions, send them through to us. We will be posting a lot of resources up on a web page in the next day or so, and that will be updated over time. We do hope to possibly have a briefing that people can use for independent counsellors independent candidates to challenge them and to educate them on why they should be fighting to renationalise the NHS. Hopefully all our attendees now are better equipped to challenge those candidates and to talk to their friends, family, communities, workplaces about what's really happening in the NHS, and that it's not just a matter of underfunding, understaffing. We hope that you do agree on our concept of renationalisation of all public services, including health services, and that you can sign up to those principles under the For the Many network banner. And, you know, one of the essential things is that you understand the need to campaign to end the integrated care systems, which are the American multiple systems which have replaced our NHS, and the support to reinstate the NHS Bevan model. And again, we'll organise another meeting to talk about social care because it deserves a meeting in its own right. We hope you've learned more about identifying targets to raise profile of campaigns, and please visit our website. And then our call to action, try and build your own local campaigns. There are resources and people will give you advice about how to do that locally. Visit our webpage, the details are on the screen now. And it will include the recording of this webinar in the next few days. Useful Twitter accounts. There's a Twitter account there for Dr. Bob Gill, one for me, one for Save Liverpool Women's Hospital. And the date of the next webinar will be supporting the right to strike in July 2024, hopefully. And then there's a final screen about how you can join the For the Many network to build a future for us all and to put people back into politics and work for it to, you know, work for the benefit of all of us rather than just the 1% and big business. Thank you very much for attending tonight, and please let us have your feedback, and hope you enjoy the rest of your evening. And thank you very much to Ali for doing all the work in the background there and preparing all the slides and bringing it all together. Thank you.
I didn't.
Thanks, everyone.
I didn't have to say all this because I'm new. But I didn't have to say anything. All these say something, but I didn't.
Okay, Sean, thank you. It wasn't really a meeting where everyone could contribute because we had a limited amount of time. So I'm sorry you didn't get to speak.
That is the reason I didn't. I want to support myself.
Yes.
I represent much the area, and I represent people with learning disabilities and the champions as well. What's the next meeting?
We'll send out information about the next meeting, and if you'd like to send us information about your campaign group supporting people with learning disabilities, we'd really like to see that, and maybe it can be added to the website, the web page on the For the Many website.
Okay.
Thanks, Sean. Thank you, everyone. Good night.
Bye.